Good morning everyone. Today we are going to continue the topic on pharmacokinetics of drug interactions part 2. This topic explains how drugs interact with each other inside the body during absorption, distribution, metabolism and excretion. Understanding these interactions help us improve drug safety and avoid adverse effects in patients. We also see the concept called the hydrophobic paradox. Most cell membranes are made of lipids, so lipid soluble drugs can easily cross them. However, the body must convert these lipid soluble drugs into water soluble forms so they can be eliminated through urine or bile. This conversion process is called biotransformation. Drug metabolism occurs in three phases: phase 1, phase 2 and phase 3. In phase 1 reaction, functional groups like hydroxyl, amino or carboxyl groups are added through oxidation, reduction or hydrolysis reactions. In phase 2, conjugation occurs by attaching polar molecules such as glucuronide or sulfate. Finally, in phase 3, drugs are eliminated from the body through kidneys or bile. In phase 1 metabolism, enzymes modify the drug by introducing functional groups. These reactions may activate, inactivate or sometimes produce toxic metabolites. In phase 2 metabolism, conjugation reaction occurs, making the drug highly water soluble and easier to eliminate from the body. So overall, phase 1 modifies the drug and phase 2 prepares it for excretion. Here, the Cytochrome P450 enzyme system, which plays a major role in drug metabolism. These enzymes are mainly present in the liver. Among them, CYP3A4 metabolizes the largest number of drugs, and CYP2D6 metabolizes about 25% of commonly used drugs such as antidepressants and opioids. These enzymes are very important in drug interactions. We see the concept of prodrugs as Trojan horse. Prodrugs are inactive drugs that become active only after metabolism inside the body. They are designed to improve drug absorption, stability and reduce side effects. An example is prednisolone phosphate, which converts into active prednisolone inside the body. And another example is levodopa crosses the blood-brain barrier and distributes the dopamine inside the brain. Pharmacogenetics, which means genetic variation affecting drug metabolism. Based on enzyme activity, patients can be classified as poor metabolizers, normal metabolizers, or ultra-rapid metabolizers. Poor metabolizers may develop drug toxicity, while ultra-rapid metabolizers may show reduced drug effectiveness. An example is clopidogrel metabolism. Drug metabolism also depends on physiological and microbial factors. Age plays an important role. Drug metabolism is slower in fetus, neonates, and elderly patients due to reduced enzyme activity. Also, gut microorganisms can metabolize certain drugs before absorption. For example, some bacteria reduce the effectiveness of digoxin. Here, drug interactions are classified into pharmacodynamic and pharmacokinetic interactions. Pharmacodynamic interactions occur when drug effects change without altering drug concentration. For example, alcohol taken with sedative increases the central nervous system depression. Pharmacokinetic interactions occur when one drug affects the absorption, distribution, metabolism, or excretion of another drug. Enzyme induces increased enzyme activity, which increases drug metabolism and reduces drug effectiveness. For example, smoking reduces the effect of theophylline. Enzyme inhibitors decreases enzyme activity, which increases drug concentration and may cause toxicity. For example, cimetidine increases theophylline toxicity. Antacids increases gastric pH and reduce the absorption of drugs like itraconazole. Chelation occurs when antibiotics bind with calcium or iron, reducing their absorption. For example, tetracycline should not be taken with milk. Protein binding displacement can also increase drug activity. For example, diclofenac displacing the warfarin and increases the risk of bleeding. Here we see that interactions with warfarin. Warfarin has a narrow therapeutic index. So even small dose change can produce large clinical effects. Therefore, international normalized ratio should be monitored within 48 and 72 hours after starting a new drug. CYP inhibitors increases the bleeding risk, while enzyme inducers increases the clotting risk. Polypharmacy means the use of multiple drugs at the same time. It is common in elderly patients and increases the risk of drug interactions, toxicity, and treatment failure. The risk becomes higher when more than 8 drugs are used together. Safe prescribing depends on 4 important factors: metabolic pathway of the drug, genetic variation of the patient, concurrent medications, and patient physiology such as liver and kidney function. These factors help in providing personalized drug therapy. To conclude, understanding pharmacokinetics of drug interactions helps us improve patient safety and treatment effectiveness. Drug metabolism, genetics, physiology, and concurrent medications must all be considered before prescribing drugs. Therefore, modern drug therapy follows an individualized treatment approach rather than a one-dose-fits-all method. Thank you for watching this lecture, and please join in another part of the drug interaction lecture.